name's Dan Joyce. I'm a urologic oncologist at Vanderbilt University, and I have the pleasure of talking with Sarah Psutka, who is a urologic oncologist at the University of Washington. First of all, Dr. Psutka, thank you for being here and chatting with us.
Thank you so much, Dr. Joyce.
You're involved in this meeting in many different ways, justifiably, given your expertise in kidney cancer, bladder cancer. We want to talk about kidney cancer specifically. You know, the recent KEYNOTE-564 overall survival data, very promising. Highlighted in many different ways throughout this meeting. Can you talk about, just in general, kind of how you see that data informing what's being presented here?
Sure. Well, I mean, this has been an incredibly exciting year. It is the first time we've had an adjuvant trial that has reported out an overall survival benefit, and a 38% overall survival benefit is a really big deal. There's obviously a lot of debate over some of the nuances of the trial and how we contextualize that within the other IO-based adjuvant trials, and I think rightly so. We do always have to be really critical of this data, but I think it's given us now an FDA-approved option that has OS benefit. It definitely, I think, has obviously superseded the role of sunitinib. I think the harm levels in the original trial reported out are obviously more favorable. And so especially when we're thinking with patients about what are the risks of taking on an additional year of therapy when you are ostensibly disease-free, it's a little bit of an easier sort of story to tell and treatment to counsel on. But it's been great because I think there's been a lot of engagement at the meeting around really trying to think about how do we select our patients for this intervention? How do we talk to people about it? And how do we really partner with our medical oncology colleagues to make sure that we're sort of, I would say, smoothing the implementation of it?
So great point. And that's the frustration I have in my clinic. Obviously, inclusion criteria for that trial, pretty broad, honestly, and with very differing risk of progression levels in those patients. So how are you counseling your patients? Are you going by the trial inclusion criteria? Everybody gets sent to medical oncology, or are you being a little bit more nuanced about it and saying, okay, you know, T2 high grade, maybe not, maybe more the T3, T4, maybe the N1. How do you go about that?
Well, I think that you do see the DFBEST benefits sort of preserved across the different risk stratification levels within the trial. Obviously, there were some differences with respect to the OS in the subsets, but those are getting to be sort of smaller numbers. Here's the way that I handle it. So first of all, I actually like to lay groundwork and give patients kind of a comprehensive plan of attack from the get-go before we've gone to the operating room. I think it's really helpful to set expectations about what treatment's going to look like, and also so they can kind of understand what their next year could look like. And I say, listen, I don't know what your path is going to be. If your tumor is the most common type of tumor, it's probably going to be a clear cell. And if I'm suspicious based on the way that the imaging looks about the staging, that they're going to have a high-risk tumor based on size and what I think the likelihood is of either venous invasion or fat invasion, I say, I think there's a chance we could have to talk about some further therapy, you know? And so I actually lay out the trial before they've had surgery, and I let them know about this data. And I say, if your path comes back and you meet the criteria for that, I'm going to ask you to have a conversation with my friends in medical oncology. I want you to hear about it, and then we're all going to decide together if it's right for you.
So obviously, patient selection, individualized patient selection is key. Whenever we talk about individualized medicine, I think two things always come up: biomarkers and advanced imaging.
Sure.
Do you see any future there right now, or is that distant future?
Yeah.
Anything you're seeing at the meeting that kind of might help inform us from a diagnostic standpoint on who those patients are going to be that are high risk?
So Dr. Tian Zhang from UT Southwestern is a medical oncologist and an absolutely brilliant mind and trialist in the kidney cancer sort of world. And she gave a great talk at the SUO yesterday, and she actually answered that question, I think, really thoughtfully. There's no biomarkers that we have that are kind of ready to go at this moment in time. We don't have anything that's FDA approved for risk stratification for adjuvant therapy. But I think there is some interesting work being done in the ctDNA space with Signatera, and there are some other methylation signature biomarkers that are under investigation, and I think there's promise there. Obviously, we can look at things like PD-L1 staining. Obviously, the KEYNOTE trial was enriched for patients who were PD-L1 positive. We can look at trying to choose those highest risk patients. And then, of course, it also comes down to the one thing we really don't have that we really need are risk stratification parameters for potential harms with IO therapy. Because the other part of all of this is we have to talk to patients about trade-offs. And that's something that I'm really interested in, which is not just the potential sort of personalized estimates of oncologic benefit that we can expect to attain by going through a year of adjuvant pembro. I don't know, many of you probably saw Dr. Pedro Barada's presentation at GU ASCO, which was a really thoughtful discussion of this trial. And he had one great slide where he basically showed the sort of the ultimate sort of survival curve, and showed that basically, you know, the folks who in the placebo arm who had this kind of durable overall survival and disease-free survival, well, we can kind of consider that they were just cured by surgery, right? Mm-hmm. The folks in the treatment arm who recurred didn't benefit from necessarily seeing that year of adjuvant pembro. Yeah. The 8% difference at the end of the curves, those are the folks who we probably really helped. Yeah. So how do we find those people? But then the other question is, of all those people who are exposed to the therapies, and you think about the harms and the potential for long-lasting, life-impacting harms that happen in a small percent, thankfully, in this trial, especially if you compare it to like the historic sunitinib data. But you're potentially rendering someone a diabetic for the rest of their life, or rendering them hypothyroid. And so those risks are real. So we do need predictive biomarkers for risk of IRAEs.
Yeah, couldn't agree more. It's something that's overlooked way too much, I think. We get focused on the oncologic outcomes, but the quality of life, of that extended life we're giving with these treatments, really matters to patients. Yeah. And it's not captured in a way that is transferable into predicting who those patients are and appropriately counseling those patients on what to expect.
It's totally true. I do want to highlight the fact that the investigators from the trial did publish quality of life data that showed that quality of life was preserved during the year of treatment, which is, I think, really reassuring. And that does, again, trump the TKI data. But again, we have to start thinking beyond just sort of traditional outcomes that we think about. We've got to start thinking about concepts such as treatment burden. You've done some really interesting work that I think is so important on cost, and you've looked at cost from sort of a societal perspective. We have to think about the financial toxicity implications of these drugs. And I think, I mean, it just highlighting your work, you showed that basically this was not cost effective if we think about our traditional sort of thresholds.
Yeah, and it was key in that study of looking at what is the probability of progression. And for a certain subset of patients with a high probability of progression, it probably makes sense. Yeah. But understanding
the highest level of progression.
Correct. Right. Correct. And understanding who those patients are is not easy. Yeah. Now, I think there's, a lot of exciting stuff in this space. Advanced kidney cancer, every time I open up the NCCN guidelines, it's changed because we have new treatments, we have new options for these patients. We have other things like advanced imaging, things like CA9 or PSMA
PET,
perhaps, with the angiogenesis of the tumor, and understanding, okay, is this going to tip us off on which of these treatments to use? Yeah. And I think that really is the future of figuring out what is the best patient for this treatment, so that we're using high value treatments and not just a one-size-fits-all approach.
And I'll just make a plug. The right treatment for the patient, the right patient for the treatment is one sort of question to answer. But we also have to make sure that we're obviously goal-aligned and priority-aligned, which means you need to talk to the patients about, do they want to throw the kitchen sink at this thing? Is that what's going to be, is that going to be the thing that makes them feel like at the end of the day it was worth it? We talk about treatment utilities in the patient-reported outcome space. Or does that patient really just value being treatment-free?
Such a great point.
And so I think that's actually something we've got to think about too, right? Yeah. And that's going to take really getting into sort of looking at the implementation and the adoption of this therapeutic sort of option. But isn't it nice to have options?
Yeah, absolutely. And you're so right. There's a difference between a high-value option for our healthcare system and a high-value option for our patient. Correct. And that high-value option for our patient totally depends on their values. So,
yeah.